a good colleague of mine teaches at UNE, so there's quite a strong connection with Dr. Shore. And Todd, do you do any time at the dental school? I know you're at the VA.
I just teach at the VA at
Yep.
the GPR
How many residents are up there?
too.
Two. Yep. They do a lot of endo, or
They do a lot. The VA sends a lot to us, but they are doing a ton of endo, and they get to do some complicated stuff. It's fun to be up there and sit down with some of these guys because the dental school training in endo, as a lot of you guys probably know, is lacking in the number of cases, and so it's been great to really help them walk them through some of these tougher cases.
great. All right, so I just started recording. Here we have Dr. Mellin. Todd Mellin is a endodontist here in Portland, Maine. He's offered to join us tonight in our conversation about a topic that's very relevant in any general dental practice, whether or not the practitioner is doing endo or not. So we're going to have kind of a conversation throughout my PowerPoint. He also has a PowerPoint which he may decide to share some stuff. But as usual, this is a discussion, so please chime in, just unmute yourself and intersect the conversation wherever you'd like. If you want, you can use the chat tool. I'll keep that open and ask the questions if you'd rather just type it in. But it's really nice that we have a specialist here, and a specialist that is very well tenured. As somebody who's seen his work second to none, there's a lot to be learned tonight, so let's take advantage of the next hour with Dr. Mellin. All right, so what I'll do, I'm going to share my screen. And by the way, Dr. Mellin is one of the few endodontists in really northern New England that does IV sedation. So if you have any patients that are severely anxious and could benefit from that kind of care, Dr. Mellin's the man. All right, Chad, let me know we
All good.
sharing the screen. Perfect. All right. So the therapeutic pulpectomy, this term comes in many different flavors, but the whole aim for tonight is to provide an alternative to antibiotic and opioid prescribing for the emergency pulpitic dental patient. Pulpitic, not sure if that's a term. Todd, is that an official word?
I think so. Now it is.
All right, now it is. We've made it official tonight. Perfect. So the patient that has severe pain that's more isolated to the pulp complex within the tooth, this being a separate conversation from somebody who's having an inflammatory reaction, such as an abscess, a draining fistula, so on and so forth. So when we talk about dental treatment, anytime I look at my own protocols, I always like to come back to this this video here. This talks about efficiency. So the first half of this video, think of dental school. The second half, where we hopefully will be tomorrow morning when we go back to practice. And it's okay if there's no sound. It's more the video.
The tires are changed at last. A crewman polishes the windshield as Holland moves away just 67 seconds after he stopped.
All right. So what's the point of that? Well, it's to help us today in creating a protocol that's efficient, that gets us out of the normal inefficiencies of dental practice. They live everywhere within every dental practice. But I think today with this particular topic, not only are we hoping to add some awareness in ways to help patients, but also efficiently, do that in an efficient manner. But before we go anywhere, diagnosis is important. Anytime we talk about endo, I think diagnosis should be, it's that boring, obligatory part of the conversation that needs to be had, especially when we're about ready to help patients, because the proper diagnosis allows us to select the patients appropriately to make sure that we don't end up mistreating them. So obviously there's all kinds of different tests. Last year we did a NECADE session on endo. We went over all of these. I put this slide up just to advocate for those in the audience that weren't with us last year to make sure that you use all of these at some point. You at least have access to these. You know, the typical endo ice is my only tool is not really truly diagnosing teeth. It'll diagnose many of the teeth that you need to diagnose, but there's reasons why these particular endodontic tests are important. Transillumination, staining, selective anesthesia. I mean, these are less common tools that I personally couldn't live without. And those within our practice, I think would agree that there's just times when cold test is not the only test that you're gonna be able to use in order to get a proper diagnosis.
Hey, Nick.
Yeah.
Can I just want to go back to that. I agree wholeheartedly with diagnosis. If you don't have a proper diagnosis, you can't possibly come up with a correct treatment. And one little tip that I'd throw out there, there's a lot of tests, and Nick's right that they all have value. But the biggest mistake that I think I see a lot of people make is you really need to reproduce the chief complaint. You know, the patient comes in and their chief complaint is heat. The first test I'm going to do is not a cold test. I'm going to test the heat. You know, I'm going to give them a cup of hot water to test, to sip on it to see if we can reproduce the symptoms. And then I'm going to selectively try and reproduce the symptoms at a tooth level. If it hurts to bite, I'm going to reproduce that pain to bite. And then we can all be confident what the problem is and what the source is.
That's great. Yeah, thank you, Todd. You know, I think back to a recent case where, you know, just that was not done. And let's just say that the sequelae of that misdiagnosis had long-term ramifications. Had a tooth sleuth been used instead of cold test, because ultimately it was a cracked tooth, I think some sleep would have been saved in that particular provider's world. Yeah, so thank you, Todd. Is there anything else, Todd, in the diagnostic world that you think would be helpful for us?
I think that's really the big one is keep testing can be simple, but you know, if you can't reproduce it, there's uncertainty, and if there's uncertainty, then the treatment you're planning on providing is probably not the right one, and that's a red flag, and you really need that's the first instance where you may want to step back and reevaluate the situation and what your plan is.
Sure.
And that's hard to do. And Nick and I were talking about this a little bit earlier. When you're seeing these patients in general, it's a squeeze in between two patients that you already have. It's at lunch, it's at the end of the day, and you're in a rush to hurry up and try and treat this patient and figure out what their problem is. And that's when you can get in trouble.
Yeah. Yeah, having workflows, algorithms, and other tools to help us with all of this is very important. This was a flow chart that Dr. Labonte had helped me with last year. We were trying to create a flow chart that really spoke to the general dentist that maybe didn't have good diagnostic skills. As somebody who's employed probably close to 20 associates over the years, and me myself being a young associate who struggled with diagnosis, and I'll still be humble enough to say I still struggle with it. A workflow like this is helpful. This doesn't provide all the answers. If anybody wants a copy we have a series of these, be happy to share them, to shoot me an email. But specifically, we want to focus on maybe not reversible pulpitis today, but the symptomatic irreversible pulpitis as the common patient that comes in with severe pain, and antibiotics are not necessarily going to be the answer. Todd, was there anything on the flow chart you wanted to chime in on?
Lingering, I would tend to, I think that's a great flow chart, to be honest. looking at it quickly, the one thing that I'm seeing that kind of pops out to me is when I'm looking at a cold test, and I really try and differentiate between a hypersensitive tooth and one that's really a linger. So in my mind, when I'm talking about a linger, it's that quick, sharp, intense pain. But then a couple minutes later, they're like, "Holy cow, that tooth is still hurting." And so when I'm using the definition of lingering, it's more along that line. It's not always like that. Sometimes you'll get a tooth that's hypersensitive, and they'll just say, "Yeah, 10 seconds later, it's still sticking around a little bit," but I wouldn't necessarily call that a linger. So I might change that,
Yeah.
plus 10 seconds to maybe 60 seconds or something like that.
Yeah. Well, Todd, I would love to have the opportunity to sit down with you and go through these workflows and tidy up these areas. I think a nice flow chart like this is missing in the profession. We spent a lot of time trying to find a really, really good flow chart that really accounted for every clinical scenario.
Mm-hmm.
So let's table that for sure. But I think that's a good point, one at which I totally agree with. The AAE, the American Academy or American Association of Endodontists, being the governing body of that discipline. Like any discipline, they produce position statements to help provide clinicians guidance on what is the standard of care, what are the expectations based upon certain clinical scenarios. And I love the AAE, some of their stuff. It's very clean, very simple. By the time they produce stuff, I think it's of very high value for general dentists that maybe don't have the command of knowledge that an endodontist has. So I encourage everybody to visit their website and get used to looking at their stuff. But this was a position statement that they produced back in 2017, and I think everybody will get a sense of where we're going. But the highlight of this particular statement is the fact that some of these conditions are inflammatory in nature and not necessarily infections. We all know that the easy thing to do is do what the patients ask for. They come in for an antibiotic. And it's difficult sometimes because that's what they're expecting, and then we either don't give them treatment or we tell them we'll keep an eye on it. The point of this position statement is that antibiotics are not always the answer. So they went through, almost in a meta-analysis fashion, went through the literature to find out, is there any supportive evidence for using antibiotics in certain situations? And the reason I'm bringing this into this conversation is because the take-home message is antibiotics are not the answer much of the time, but immediate treatment is. So if we go down, we can see, and Todd, I'll let you chime in once I get to the end of this summary here. Multi-drug resistant bacteria cause 23,000 deaths every year in the US alone. That's pretty substantial. And as clinicians, if we're prescribing these antibiotics, we have the ethical obligation, and one could surmise the legal obligation, to use these judiciously. The term used in medicine is antibiotic stewardship, meaning being responsible in how you prescribe. Well, this particular position statement says, well, not only should you not prescribe sometimes because the science isn't necessarily there, but there are other ways of treating the patient, such as immediate treatment, and that's the kind of take-home message, the therapeutic pulpectomy. This right here, sorry, let me go back. This is the summary of the aspect of this particular position statement that dovetails to what we're talking about today. Studies have shown that adjunctive antibiotics are not effective in preventing or ameliorating signs and symptoms in cases with irreversible pulpitis, symptomatic apical periodontitis, or localized acute apical abscess. When adequate, so that's an important aspect here, when adequate local debridement medication and incision for drainage, if indicated, have been achieved. So this is the governing body to this part of our profession, basically saying, be careful in how you use antibiotics. It's not the magic bullet that sometimes it is. Sometimes that is the answer. But it's an easy way to get the patient out of your chair. And I'm advocating that we potentially have another tool in the toolbox. So the take-home message here, antibiotics for every pulpitic there's our word again, patient is not necessarily the scientific, responsible, and ethical answer. Iatrogenic causes of bad medical outcomes is the third leading cause of death in the U.S. That was a study done by JAMA sometime in the past 10 years. It's also in Complications by Atul Gawande. If you've never read Atul Gawande's work, highly recommend it. He wrote Checklist Manifesto, but he has a book talking about how doctors are often the cause for bad outcomes. So I'm going to go back, Todd. I'd like to hear what your thoughts are on this position statement when it comes to antibiotics.
Yeah, so I do agree with that. My mentor in my residency was a PharmD, and she was a huge advocate of prescribing antibiotics appropriately. And so, number one, getting back to what we were talking about already, if you have the proper diagnosis, it dictates what happens next. And so an antibiotic is only effective in an infection secondary to a necrotic tooth. So if you have a patient, and we see this all the time, who's been up for 2 nights with severe cold sensitivity, the antibiotic is just offering maybe a placebo effect, but it's not actually doing anything to make them better in any way. And as Nick said, you're giving a drug with very little benefit, and then you only have risk. So pseudomembranous colitis, antibiotic resistance, you're asking a lot of that antibiotic, and the only thing that you could really get out of it is really a bad outcome. But we see that a ton, and so thinking about when it's appropriate to prescribe an antibiotic is important, and that all starts with the diagnosis. I'm sorry. So irreversible, you've got to treat the tooth. That's really the bottom line. If there's swelling and infection, what I was taught in my residency, we're going to open the tooth. We're going to try to establish drainage. And if we can do those things, a lot of times we can avoid the antibiotic altogether.
Yeah, great. Can you restate the statement that you said? So this is a question, go ahead and provide the answer. When are antibiotics a good idea in endodontic therapy?
So if there's an infection, and so we see a patient with swelling, and if the swelling is a cellulitis, so just to quickly talk about that, a lot of times you'll see swellings occur rapidly. They woke up that morning and they were swollen. That's a cellulitis. I'm not going to get any drainage. I need to put that patient on an antibiotic ASAP. If the swelling has been there, I call it an old swelling or an aged swelling. It's been there for 3 or 4 days. It's slowly getting worse. It's fluctuant. That's a swelling that I can IND or do a pulpectomy and IND essentially through the tooth, establish drainage, maybe leave the tooth open. If I can do those things, I'm probably not putting the patient on antibiotic. If the swelling is large, obviously, no matter my treatment, I'm probably going to put that patient on antibiotic.
Yeah, that must take some cojones to not put, sorry for the term, but to not put a patient on antibiotic that has that quote unquote more latent swelling. I'm not sure the term that you use, older swelling. But that's based on, that's a scientific perspective. So you're using science to guide you in that decision making. I love that. I love that perspective that patient 9 times out of 10 is getting an antibiotic by most general dentists.
Right.
I think you articulated that very well. Yeah. Does anybody have any questions on antibiotics for Todd? I go on. This is a great article to read. It does talk about the fact that the standard of care is to prescribe primary or adjunctive, primary being that's the only treatment that you provide as a first-line defense, or adjunctive in conjunction with antibiotics. with local debridement. So that's what Todd was just saying here. If you have a spreading infection, somebody cellulitis, that's the person that needs the antibiotic, not the patient that comes in. They had a cleaning 2 days ago, so the tartar's off their teeth, so they have hypersensitivity. I've seen that happen, and that's just, that's bad diagnosis and bad decision making moving forward. Sounded like somebody was going to ask a question.
I got a question.
All right, Chad.
If treatment is not readily available, but there is not a indication for antibiotic yet, do you ever prescribe the antibiotic with the instructions to like wait for swelling to happen, or have this just in case type prescription?
No, because I guess it depends on what the situation is to begin with. If we're dealing with a irreversible pulpitis, and for whatever the reason I'm not able to manage that patient on that day, then I'm going to move to NSAIDs, Tylenol, maybe add oxycodone on top of that, and help to treat their symptoms until we can perform definitive treatment. If I feel like it's an infection problem and I'm not able to treat for whatever the reason, then I'm going to put them on an antibiotic, because I want that antibiotic working before they get swollen, before they develop that cellulitis. Does that answer your question?
Yeah.
Yeah, thank you, Chad. So this is a statement that comes from this guidance. It's a summary statement. This leads to the question of whether prescribing antibiotics for patients in these situations is appropriate, warranted, and defensible from a medical legal perspective. The fact that this sentence is here in this position statement is all a litigating lawyer needs to really make your day a bad day. So got to know what's out there. This is very, very clear. If you do prescribe antibiotics, you should have really, really good rationale. Where does rationale start? Proper diagnosis. Any thoughts or questions on this?
Hey, Nick, I might just add one more thing. I'm sure you guys all know this, but when you're evaluating these patients, you also need to understand when it's starting to get dangerous, when it's going from something that we can treat and manage to something this patient needs to get to an oral surgeon ASAP or straight to the emergency room. And I see these cases, I don't know, once every couple of years, where it's the swelling just occurred in the last 24 hours and they're really swollen. They're not quite having difficulty breathing and swallowing. But if I put that patient on an antibiotic, it's going to take 24 to 48 hours for that antibiotic to even start to work. And in the meantime, they're going to be getting worse. And so when I see those patients, it's not worth saving. The risk of them having a really bad outcome is not worth saving the tooth. Just get them to a place where somebody can manage the airway, IV antibiotics, and that sort of thing.
Yeah, Todd, great point. What is the line in the sand? When does that patient become high risk that we should refer to the oral surgeon specifically?
Number one, the speed of the onset. If this thing is moving quickly, that's a huge red flag. And then if we're looking at submandibular buccal space swellings, I'm thinking about referring at that point. When you have multiple spaces involved
Sure.
in the swelling.
Yeah, I think you articulated it well earlier. Those more localized situations are one thing, but once we start seeing cellulitis, and for those who maybe don't understand cellulitis, it's a term that we learn in school. It'd be important to know what that is and how it's different. What are spatial infections? It's not something we see in a general dental practice, but when he speaks of the submandibular space and the buccal space, these are essentially compartments within our oral facial complex that when infections enter those spaces, they can progress rather rapidly because they have the space to progress. And because they have space to advance, they can enter other parts of the head and neck anatomy, which is why it's very important. So cellulitis and spatial infections would be an important topic for us to, really have maybe not a knowledge as competent as an oral surgeon, but I think we should know what those are. So thank you for bringing those words up, Todd, because I think they're an important part of understanding who the patients are that need to be referred. So yeah, we continue here, but in the sake of time, and I'm happy to send this PowerPoint at the conclusion here. So what do we do? So we have these patients that come in. Again, we're trying to focus on the, not necessarily the spreading infection, but more the irreversible pulpitis patient, or the patient that has, a severe situation where antibiotics are not going to be an answer in and of itself. So the therapeutic pulpectomy, that was the term that I was taught. Pulpal debridement is another term, so there's different flavors of this particular description. But in a nutshell, and I know this is a little bit kind of basic, but I think it's an important topic to discuss, in great part because there's certain codes that we need to use within the CDT code classifications, and understanding what you're doing is important. So again, very basic, but pulpotomy being defined as removal of the pulp chamber contents, the blood supply, the lymphatic system, and the nerve, where a partial pulpectomy would be something at some point down the canal system, and then a full or a complete pulpectomy, removal of all of the tissue. Todd, do you have any comments here? I mean, this is the bulk of the conversation here. Is my question to you, Todd, is can we do a pulpotomy in an adult that has irreversible pulpitis? If so, who are the patients that we would do it on? Do we have to do a complete pulpectomy? Is formicrosol a tool that we can use in an adult in these particular situations? Does it still have its place outside the pediatric patient? So what are your thoughts about this picture when we want to get the patient out of pain?
So good question. Can you guys, I lost one of my AirPods. Can you guys hear me okay?
Yeah.
Okay. So the gist is with these treatments, I really don't distinguish too much pulpectomy, pulpotomy. It's a debridement, as Nick was saying, and you don't really need to do too much to eliminate the symptoms for a patient. So it could be simply opening the tooth up, going into the orifices with a round burr or a 3 gates, and call it good. Cut and cavit and have them back when you have time. And you could go as far as getting what I would typically do, because it doesn't take me too much longer. I'm going to quickly get lengths and just run a rotary file close to length. I don't really care too much. But really the tissue that's causing the issue is in the pulp proper, and it's not typically the radicular tissue. So as long as you're removing that pulpal tissue, the patient's gonna be better in these cases that we're talking about, in these IP cases. Necrotic cases, infection cases are obviously a little different than that if you're trying to establish drainage.
So to summarize what you're saying, the pain perception that they're having is coming from you call it the pulp proper, which would be the pulpal tissue within the chamber?
The coronal pulp.
The coronal pulp. So most of the time, if we're able to establish removal of that, we've, in most patients, hopefully removed the pain symptoms themselves?
90+% of the time.
Okay. What would we see if the pain continued? Would it get worse? Would it get a little better, stay the same, if it's more radicular in nature?
Yeah, probably all the above. It could go any number of ways, because you have to remember it's a traumatic procedure.
Sure.
So with the trauma of the procedure, you're going to generate some pain. And so what I'll often tell patients is you're still going to have some symptoms, but you're most likely going to feel better.
Yep.
But I'll also warn them that you might get a little worse before you get better because of the trauma, because of the additional inflammation. And that's where the adjuncts of the NSAIDs and stuff like that come in.
Yeah, great.
But getting rid of the inflamed tissue is really what's going to help them. I don't use formicreosol. I'll just irrigate with sodium hypochlorite, dry it, cotton pellet. I might use calcium hydroxide. There's some evidence in the literature that it might have some anti-inflammatory properties, but I'm not too sure I buy that.
Yeah. Do you ever have situations where the radicular pulp bleeds so profusely that you just can't control it? And if so, how do you handle that?
Yeah, so that will happen. And you'll see it in these patients where they're not having any symptoms at all, and it's like a volcano. In those cases, the idea, or what I'm thinking, is that the inflammation is not just in the coronal pulp. Now it's in the radicular pulp, or maybe even in the PDL. And so in that case, then I'm trying to remove as much of the tissue as possible. So I'm now trying to get lengths, if I can, estimated lengths, get the rotary down to close to length, just to try and remove as much of that tissue as possible. Sometimes you can't, and it still bleeds. This is a different situation than, say, a patient's swollen and you open the tooth up and you're getting drainage. You would maybe want to leave that tooth open, or maybe consider leaving the tooth open. But in these vital cases, I'm definitely going to put cotton cavit, and it could be a bloody mess. You throw some cotton pellets in, you're trying to get the cavit on, get it sealed up. They're not going to have that pain that you would see in a case where there's an infection and you're capping this pressure system, so to speak. And they still do well afterwards. Once you get rid of that inflamed tissue, they're going to improve.
Right. Yeah, this is great. What do you put over, in the case of a pulpotomy, what do you put over the radicular pulp? You know, the access to the orifices or orifi. Are you just putting cotton right over the top? If you've got hemostasis at that point, cotton and cavit, and that's it?
Yeah, yep, just your temp.
Yep. That's great.
It doesn't need to be fancy at all.
Yeah. You know, Todd and I were talking before we hopped on the call, and he made a very valid point, which is what I was hoping to make, and hearing it come from a specialist such as Todd was very nice. His comment was something to the effect of, "This isn't difficult. You know, this is very easy to do if you have some basic understanding of, endo accessing the tooth appropriately. Obviously, if you've never accessed a tooth, or it's in dental school, maybe you did number 8 and that was the only endo you did. You know, I think understanding how to access a tooth. But these vital cases, the pulp chambers are pretty big. It's not like you're going through calcified tooth structure and you're having to get an ultrasonic tip out. You know, it's really like you said. You take a what did you say, a number 4 or number 6 round burr and drop it in. Can you talk to talk to the process again when you access this tooth? What burr do you use again?
So for me, for accessing the tooth, I use a 557,
Yep.
which is like a 1557 with rounded. It's a little rounded at the end.
Yep.
I use that to actually make the access. I find that I would advocate against using round burrs to access teeth and endo, and that's just a preference I have. But I find it when you're using a round burr, and when I see the residents at the VA using round burrs, everybody's taught to use round burrs. This is a little pet peeve of mine. It's really hard to make a nice clean access. The round burrs just kind of chatter, and they cause these divots. When you use something like this 557 burr, I think you get a nice cleaner access. I think you have a lot more control. That's just my preference.
Yeah, I like it.
Once
It's also side cutting, so you
it's
can
also side cutting,
open it up
so
more efficiently.
so you can open it up more efficiently. I don't find that I use tapered diamonds, like crown prep diamonds, a lot as well
Yep.
to shape. Um, Once I have it open, then you can either use a slow speed round burr at that point to help to remove the pulp tissue, or gates.
Hey,
Yeah.
Todd, I'm Zach Regan. Thank you for coming on today. We're glad to have you.
Yeah, no problem.
I'm just wondering, just going back to antibiotics, because it's one of my favorite topics of discussion in dentistry. If the reality of the busy dental practice is upon you, so, you got a patient for 30 minutes limited, you have, your mother-in-law crying in the chair next door, and 5 hygienists waiting for you to come see them. The reality is it's not feasible for me to get in there and access the tooth, right? And I know we just spent a lot of time discussing that patients don't need antibiotics the majority of the time, and I agree wholeheartedly, especially when there's no obvious cellulitis or infection. But what are you thinking for that moment, that scenario?
So this is where I'm gonna put a plug in for me. Um, if you in your circumstance you can't manage that patient on that particular day, that's what we do. That's kind of my whole day, is finding a way to squeeze these guys in. And Andy and I can be really efficient. I can get that patient in and out in 20 or 30 minutes tops. It's just from doing it for so long and just being efficient. So that's what I would say. Number one, if you as a general dentist are not able to treat that patient, you should make a phone call. Perhaps that would be an appropriate time to refer. Other than that, if that's not an option, then going back to what the diagnosis is, what's your diagnosis and how are you going to treat that particular problem? So if it's a pulpitis, you need to get them on an NSAID. You need to control the inflammation that's causing the symptom. Or if there's infection, then obviously the antibiotic is the right choice. But that's what I would do. If I couldn't see them, then I'd be putting them on NSAIDs, a combination of NSAIDs, Tylenol, and maybe some Oxy to get them by until I had time.
So Todd, I have a slide a little bit farther down, but since we're on the topic, what are your thoughts about steroids in these situations?
I like steroids. I don't necessarily use it to, and that might be an appropriate thing to do for Zach's question. Where I'm more often using them is that patient where the tooth is so hot and they are so uncomfortable. And just like we were talking before, I've stirred that pot up. They can get worse, and they do get worse on occasion. And when it does get worse, they are super unhappy.
Right.
And so what I'll either do is just a bolus of dexamethasone. We keep it 0.75 tablets in the office, so I'll give them 4, or I'll prescribe a Z-Pack. And with the steroid, the single bolus dose, that's all they need. We don't taper it at all. And I'll do that while they're still numb before they leave the office. And what I find with that is if I can predict it, I don't put all my patients on a steroid, but I try and predict those cases that I think that are more likely to have a problem. They'll get it, and they don't suffer as much.
Right. You just said Z-Pack, and we'll talk a little bit about azithromycin. I'm assuming you meant the Medrol dose pack?
Yeah, sorry. Yeah.
So for those out there who don't know, Medrol dose pack is kind of it's a nice way to enter in the world of using steroids to help patients in inflammatory situations. I would definitely recommend doing your homework on who are the patients that you can medically do this with, diabetics, for example. Do your homework on understanding who are the patients you can give those for. With that said, Zach and I have used Medrol dose pack a lot, and it has changed a lot. I think a patient who comes in pain, and I think this is what you're saying, Todd, is you put them on a steroid or even an anti-inflammatory, and then you treat them 2 to 3 days down the road, your post-operative complications are often a lot better because their baseline was a lot better upon treatment.
Yeah, for sure.
Yeah. Cool. All right, let's continue going down. I think we've hit this here. The check pulpotomy, not the topic of conversation. Do you ever do any of this, Todd? This is more of a...
We do a fair amount of this. Yeah.
So this is, can you talk about what is the diagnosis or the situation when you would do this?
Kids. With kids, I'm trying to avoid the endo at all cost. I think the lit says that 4 years after the tooth is erupted, the apices are fully formed. I'm not buying that, because what I see when I treat these kids is that anatomy is just wide open. And what you find is these canals, say a mesial root of a lower molar, where in an adult it's clearly 2 separate canals. In a kid, that's going to be wide open. It's almost interconnected completely all the way down to the apex. And so that is such a hard situation to predictably seal. In fact, I saw a patient, I think it was this summer, that I treated when she was 10, 11. And she admitted that she was not the best patient. And it was probably one of those things, you're just trying to get it done. The kid's miserable. And here she is 10 years later, and the endo's failing. And it's not necessarily my fault. It's not her fault. It's this situation that's really tough to deal with. To seal, the patient management can become a little bit of an issue. All that's avoided by doing this procedure, which I love. I'm a huge advocate.
Yeah.
So
it wasn't necessarily a topic for today, but I think it lends itself nicely into at least the execution. I think the execution of this technique in an adult, in an emergency situation, is what we're looking to do. But I'm happy to hear that this is a tool. You probably don't use the round burr like the image shows here.
No. But this is that, and I could talk about that for a while. But that's a great tool for general dentists, and I'm a huge advocate that general dentists should know how to do this. It benefits the patient so much. They can avoid the endo altogether. It's a great service. So
well, let's if you're open to it down the road, let's have our 1 hour session on maybe more trauma in the pediatric, and kind of focused on this technique here.
Yeah, for sure.
Yeah, thank you for your insight there. I put this here. This is what we recently came up with. This is our pulpectomy tub. So this is an attempt at trying to be as efficient as the PIC crew was in 2013 versus the 1950 Indy 500. So what we were finding, even though we have we have 2 endo carts that have everything in it, doing a full endo treatment, there's more stuff involved, so there's more stuff to get out. We were bringing the cart in, and the assistants were kind of in that rut of, I'm getting everything out, and we don't need everything. So we came up with this simple box here. So all I'm trying to say is, if you decide to do this, have a very simple, succinct set of tools that you need for this very specific thing. EDTA is not something I would probably use in a pulpectomy setting. I wouldn't use chlorhexidine. I would just use bleach if I got into the radicular pulp. Todd, do you see any reason to use EDTA or chlorhexidine in these circumstances?
No, I would just use bleach.
Yeah. So I think that just found its way in here. Some paper points. Trying to get all of the pulpal tissue out is the maybe gold standard with this. Leaving a little bit of pulpal tissue that communicates with the PDL might have a remnant effect. So I think having something simple like this is really what we're advocating for, as we can see here. But wait, I swear antibiotics is still the answer. in the sake of time, I'm going to keep this brief. I wanted to go over this one particular topic. Todd, you were talking a little bit about colitis. This was an interesting comment that I found when I was looking for these slides. Really, we should never use Clinda anymore, according to this black box warning. Dr. Regan was doing a maxi course recently, and I think they strongly advocated against it. But it's now standard of care to not use clindamycin, or the expectation is to not use Clinda. I think azithromycin is really the tool of choice. Are you still using Clinda? Do you see any reason to use Clinda in light of this particular topic?
So the problem is, and I've had this conversation with physicians who advocate for azithromycin. The problem in my world is it's just not as effective as either amoxicillin or clindamycin. So I've got that patient heading in the wrong direction. I need to get that under control ASAP, or they may end up in the emergency room. So in those cases, I'm doing a quick risk benefit analysis, and if I feel like they're better off taking the risk of the pseudomembranous colitis for the benefit of getting this infection under control, I'm going to go with Clinda. So I don't think you can say don't use it, but you do definitely have to be thoughtful about when you use it.
Sure.
And you've got a little buccal swelling. It's not too bad. You put them on a Z-Pack. If it works, golden. You've reduced your risks. You've got the benefit you're looking for. But you also have time, if it does get worse over the following 48 hours or so, you have time still at that point to switch things up, to add metronidazole, or to switch them over to clindamycin if the Z-Pack isn't effective.
Yeah, and that was something that came up here, talking about PenVK with metronidazole. We've been using, that's Flagyl. We've been using this concoction of a kind of a broad spectrum antibiotic with the anaerobe focused metronidazole. In the perio world, they call that the Van Winklehoff cocktail. We've had a lot of success using this. Could you say, at least for us clinicians, general practitioners that maybe don't have the confidence to use Clinda, that this would be an okay supplement, using amoxicillin and metronidazole, or here they say penicillin, but I would use amoxicillin.
Yeah, I would use amoxicillin. That the nice thing about penicillin, I use the 875s. The patients need to take it in order for it to be effective.
Sure.
And so if they're just taking it twice a day, they're going to take it, as opposed to penicillin. You've got to take it 4 times a day. You've got to plan it around meals and all that. It's they're never taking it right. So amoxicillin with metronidazole, I find it really effective in those stubborn infections. We'll start them on amoxicillin. Rarely, I think I can, once every 6 months, maybe once a year, I may need to add the metronidazole on top of that. I think I just did that a couple weeks ago.
Sure.
And that's always effective.
Yep. I had a little bit about buffering, talking about the use of sodium bicarbonate. The reason I put this in here, getting these patients numb is rather difficult. Where we only have 8 minutes left, and I try to keep this under an hour. Otherwise, we'd probably go all night. I'm going to table this conversation, but I just want to put an advocation for the use of buffering in this patient population. So if we're going to access these teeth, oftentimes not only are they hyperemic, but they're rather hypersensitive too. So having a full skill set in getting teeth numb is really the point here. It's not just using buffering agents, which it's changed our practice for sure. But having things like intraosseous injections, PDL injections, gough gates to get farther away from the inflamed nerve. So having different tools to get these patients numb, I think, is very important. And I'm going to save this buffering protocol for another day. I just wanted to throw it out there. What are your thoughts, Todd, about these patients when they call the practice? Do you ever advocate for them to get on an NSAID ahead of time so that your anesthesia is more predictable?
I will. Most times they're on one. If they're in pain, they're taking one anyway. I think we do find that the whole procedure, the more comfortable the patient is before we do anything, the more comfortable they're going to be during the procedure. So, getting them on a anti-inflammatory preoperatively is probably a good idea for sure.
Yeah, great. All right, we have 6 minutes left. Does anybody have any questions for Dr. Mellin? I think he'd be more than happy to answer any endo questions if anybody wants to unmute themselves.
Todd, what's the standard of care for doing an apicoectomy to seal the apical segment after you've sectioned it?
As far as what material we're using?
Yeah.
That's actually a really interesting question.
Leave it to Regan to throw in the highly surgical, complicated question with 6 minutes left.
Yeah.
Todd, while you're at it, do you want to talk about the New Testament, the Old Testament, the Quran, and the meaning of life? No, it is a good question, though. What are your thoughts?
Briefly, my thoughts with apicos is that we're really dealing with extraradicular biofilms. And so if the endo is done well and we've got a case that's failing with a large lesion, I'm not really trying to treat the end of the root because I don't necessarily believe that that's the problem. I'm trying to treat the radicular biofilm. So I'm not always even resecting. If I am resecting, I'm using endo sequence, which is a bioceramic putty. Or MTA, and I'm resecting those cases where there's apical resorption, where we weren't able to manage the canal via orthograde treatment, but not necessarily if it's just if I did endo on the tooth not too long ago, maxillary premolar, huge lesion, 10 millimeters in diameter, I'm just going to debride the lesion.
Oh, thank you.
Hey, Dr. Mellin, John Lee. I was hoping you could quickly touch on leaving a tooth open following, I guess, a pulpectomy or anything when you're trying to drain it, and if you have a good protocol for that or good workflow.
Yeah, that's a good question as well. For the longest time, I wasn't doing it because everybody, my mentors were. It's something we used to do a lot. And then it became out of favor as I was going through my training. And then I find myself doing it more. And I'm doing it in those cases where there's an infection, you get into the tooth, it's draining. I'm not going to plug that hole. I'm going to let it drain for a couple of days. I'm getting them on an antibiotic at that time as well. I'm just going to let them get better. I'll follow up with them in a couple of days. And then we'll isolate, we'll irrigate really well, and then we'll seal it up with just a temporary at that time. I may even medicate with calcium hydroxide, but I'm not attempting to finish it at that point because we're still going to have some drainage, but I just want it under control enough that we can seal it up without creating more problems for the patient.
Thank you.
Yeah, thank you for asking that question, John, because I was surprised that was still something. During my training, it was during the time when it was falling out of favor. My understanding this whole time is that it wasn't, but another tool in the toolbox for sure. Any other questions for Dr. Mellin? All right. Well, thank you, Todd. This was as good as I thought it would be. I'm really hoping that we can get you back. There's a whole host of topics here. As I discussed before we hopped on this call, the aim here is to make dentists better by just conversations, being better with treatment planning, being better with diagnosis. We're going to get better and faster by doing things, but if we don't have conversations with our colleagues, I don't know if we're ever going to get to the level that I think our patients deserve. And I think this conversation tonight really moved the needle for me. I have no doubt it moved the needle for a lot of people here. If anybody would like some CE credits, we can issue those. I would ask you to email Julie. Julie's on the call here. Julie@saccoriverdentistry.com, and she can issue you the credits through NECADE. So you have a 1 hour credit for your time tonight with Dr. Mellin.
Yes, perfect. Please do.
All right, thank you, Julie. And it's Sacco, S-A-C-O, riverdentistry.com. And one more thing, I know we talked about it, Todd offers a very special skill set. Patients who are in dental pain often are anxiety patients, and he's in Chicago right now doing his IV sedation recertification with some other specialists from the state. Please keep him in mind. Endodontic Associates, they have been a partner of mine for more than 10 years. And one of the things I love about Todd and Andy and the other associates that they've had over the years, they're very approachable. So if you ever have any questions, sorry, Todd, I'm putting a plug for you. I bet if you reach out and ask Todd a question, you're going to get the same level of compassionate response that you got tonight. So thank you again, Todd. Thank you, everybody, and have a good night. Tom Brady's playing tonight, so my wife is making me watch Tom Brady tonight.
Have a good night.
All right, take care, everyone.
Thank you.